chairs, dear Marek, dear Professor Feldberg, dear colleagues. I'm very happy to be here today. Thank you so much for this very kind invitation to this beautiful country. I really love it. And thank you for this very warm welcome. So I'm very happy to discuss with you now sex and gender difference in my main topic. It's obesity and diabetes, in fact. So I will address shortly epidemiology, pathophysiology, sex and gender-related risk factors, complications and comorbidities, and then turn to treatment and prevention. Everything in 35 minutes, I hope, so please don't be afraid that it will be too much. It's very clear nowadays that we have a huge increase of non-communicable diseases all over the world. And both sex-related biological factors and also gender-related social factors play a big role in this tsunami. I didn't understand what you said before, although I had a very nice translation by Professor Feldberg, but I think I heard the word tsunami. I don't know if it's correct. So we can really talk about the tsunami if we talk about obesity and also diabetes, mostly type 2 diabetes. And the non-communicable diseases, it's obesity, diabetes, cardiovascular disease, cancer, more or less. So diabetes is really among the biggest of the 21st century global health challenges. And we have the epidemic increase of metabolic diseases all over the world, as I already said, but particularly in the low and middle income countries. And the combination of diabetes and obesity, because mostly it goes in parallel, the most important risk factor of type 2 diabetes is in fact obesity. So we also talk about the new term diabesity. And it's clear it cannot be the biological factors, only a small part. It cannot be the sex-related factors that contribute to this huge increase. But it must be our lifestyle. It must be the adipogenic and diabetogenic environment leading to this huge increase. If we talk about diabetes, it's clear that it's a group of heterogeneous diseases in which clinical presentation and disease progression may vary considerably. So we have pre-diabetes, precursors. It's impaired fasting glucose, for example, which is more common in men than in women, and impaired glucose tolerance, and this is more commonly seen in women. And this is important because fasting glucose, you can easily find it by routine measurements, but impaired glucose tolerance, you have to do the oral glucose tolerance test. So it's not so convenient, it's more time consuming, and so it's not so easy to detect women at risk. And if we look at the group of diabetes, most cases are in fact type 2 diabetes, it's about 90%. And also pre-diabetes progresses in about 40% to type 2 diabetes. And another very important pre-type 2 diabetes class of diabetes is gestational diabetes, so a female-specific class of diabetes. And we know nowadays that about 15% of all pregnant women, we have now criteria all over the world. We use the same criteria. I think also in Israel, you use the new criteria, which were also adopted by the WHO recently. And so 15%, so it's a huge number, and they have very high risk to develop type 2 diabetes later on. And also obesity and overweight, again, is one of the most prominent risk factors of gestational diabetes. So if we look at the prevalence rates of prediabetes, diabetes, and overweight and obesity in men and women, it's clear that there are big differences all over the world between the countries and the regions, and there are also some differences between the sexes, but it's not so big as the variation between the countries. And as I already said, women have more often at all ages, as you can see, impaired glucose tolerance. It doesn't depend how old they are. But on the other side, if we look at diabetes, it's clear that we have more males nowadays all over the world, also in Austria, I'm sure also in Israel, with diabetes than females. Only at a very old age, we have a little bit more females. And if we look at the BMI, these are global data, then we have more overweight younger men, but more obese elder women. And so obesity is really seems to be, just again, please think about doing an oral glucose tolerance test if you have women at risk, if you have women with hypertension, hyperlipidemia, or overweight women, then please do an oral glucose tolerance test to detect early forms of diabetes. But we really see a huge increase of obesity and even severe obesity all over the world. Even it's the same in Europe, the blue color, or also in the Middle East, and particularly we see this huge increase, that's the most recent data, in women. It's more prominent than in men, and it was projected that by 2025 obesity prevalence will reach 18% in men and surpass 21% in women, and severe obesity will surpass 6% in men and 9% in women. I know you will have another lecture with topic obesity, so I'm not sure if there will be controversial data, but I think more or less it will match. But looking at the diabetes epidemic, then we also see this increase. It's here the age-standardized diabetes prevalence rates, the change during the last decades. And what you can easily see is there are, again, big differences between the regions and countries, but also big differences between men and women. For example, we have Western high-income countries. Here you see that we have a higher increase in men, or also in Central and Eastern Europe. On the other hand, Middle East, Central Asia, North Africa, for example, or also other regions like South Asia, there are many more women who have a higher increase of age-standardized diabetes prevalence. But overall, we can say about 10% nowadays is the diabetes prevalence rate in males and a little bit less in females. So there are not so many differences regarding prevalence rates between the sexes, but it's a little bit more males. If we look at the global decomposition of changes in the leading causes of death, again, changes during the last decade, we see that diabetes is now among the top 8. And we also know that diabetes often is not detected; it's undetected, and it's one of the major reasons that people develop cardiovascular disease. So in many cases, it's not really known; it's undetected. But still, it's one of the most prominent causes of death, and this is also due to a change to population growth and change due to population aging. And we even have a little bit a decrease in the leading causes of death due to diabetes, due to age-specific and cause-specific mortality rates. So mortality was decreasing in diabetic patients, sometimes even to a greater extent than in non-diabetic patients, as recently shown, for example, in Denmark. But still, patients with diabetes have a much higher mortality rate than non-diabetic patients. And disability-adjusted life years, another important parameter attributed to risk factors in 2015, we can again see that high fasting plasma glucose and high body mass index are again among the top risk factors. And again, and in this case, you clearly see that's a little bit more important for women than for men. But overall, dietary risk accounts for a big part of the disability-adjusted life years in both sexes. So we have lifelong impact and interaction between sex and gender, between biology and environment, nature and nurture on development and outcomes of type 2 diabetes. And this starts really very early. It starts already in mothers and fathers if they are overweight and depending on their diet. But then further on, it's clear that both sex and gender contribute to the pathophysiology of diabetes and also of its complications, and obviously also to mortality. And in fact, it starts really in utero. It starts during gestation. So we know that environment affects the phenotype through sex and timing-specific epigenetic modifications. And for example, there are many data from animal studies. They are also summarized in our recent review, but there are not so many data in humans. That's a problem. It's not so easy to study epigenetics in humans, but there are data from malnutrition during gestation from famines. We have the big Dutch famine and also in other countries famines. And here are data from the Dutch famine, people born in years where the country had a famine. And if you study these people when they are adults, it was shown that exposed siblings compared to unexposed siblings, they have a permanent modification of the methylation pattern of insulin growth factor. So this is important for metabolism. And also, if you again look in the patients who had malnutrition during gestation and in adulthood, it was shown that there is really different epigenetic profiles between men and women if they were exposed to the same nutrient limitation during gestation. And these are genes that are important for inflammation, for immunology, glucose and lipid metabolism. So there are sex dimorphic effects of epigenetics. And we also could look at on data of the Austrian population, because also in Austria we had famines. Maybe this is not so well known, but in relation to the world wars, we had also 3 periods where we had severe famine. And if you look at the years of birth of the Austrian population, you see that, as expected, we have the increase of diabetes prevalence with increasing age. So starting from the age of 50, we have an increasing rate of diabetic patients, but you also see these 3 peaks. And this was related to the famines, the years of birth during famines in Austria. And you also can see that we have more males, the blue colors, than females, especially during the famines. So it seems that males are more vulnerable to malnutrition during utero. And this is also supported by animal studies. There are many animal studies also showing that males seem to be more susceptible to negative influences during gestation. Also in Austria, we have a little bit more males than females overall. This is the sex ratio, but only at young age we have a little bit more females, not significant, but more. What can be the reason for that? It's very easy. It's the gestational diabetic women. So it's very important to ensure sufficient nutrition already in prenatal and early stages of life. So let's turn to biological differences again. We know that diabetes is a polygenetic disease. There's not one gene that's affected. We have many genes. And for BMI, on the other hand, it has been recently shown by genome-wide association studies that there are about 100 loci associated to BMI, and there is very strong support that the most important physiological system is the central nervous system related to obesity susceptibility. And it was also shown in this study that 2 loci showed clear evidence of heterogeneity between men and women, and both had stronger effects in women. So there are really many physiological sex differences in metabolism and energy homeostasis. Just let's stress some of them. For instance, women have been shown to have higher central leptin sensitivity, whereas men have higher central insulin sensitivity. On the other hand, regarding peripheral insulin sensitivity, it's known that females, starting from puberty onwards, have better insulin sensitivity. Also, females have lower food intake, lower energy expenditure. They have more subcutaneous fat mass, they have less visceral fat mass, lower liver fat mass, lower muscle mass. There are changes, sex differences in adipokines, important for glucose, lipid metabolism, and body fat distribution, also like adiponectin and leptin. And even there are differences regarding free fatty acid oxidation. So we know that in relation to males, it's more important in females during exercise, and in males, for example, glucose oxidation plays a bigger role during exercise compared to females. And we have higher fasting glucose in males, as I already said, and higher 2-hour glucose levels during the oral glucose tolerance test, for example, in females, higher postprandial glucose levels in females. And why is this the case? We also tried to find some causal relationships, and what we found, we studied glucose absorption in healthy men and women, and we could clearly show that there are sex differences in gut glucose absorption rates during an oral glucose tolerance test. You see that males, they have the peak, the fast peak of glucose, but then there is this slope decreasing more quickly in males, and women have higher glucose levels during the OGTT at 120 minutes when we define, for example, glucose tolerance. So this could also contribute to higher prevalence of impaired glucose tolerance in women, that they have this prolonged gut glucose absorption. And there is also a negative relationship between body height, fat-free mass, and gut glucose half-life. So all these anthropometric parameters could contribute to the sex difference in glucose absorption and glucose tolerance. If we talk about hyperglycemia or diabetes, it's also important to look at 2 parameters, insulin sensitivity and insulin secretion. And if you plot these parameters, you will get a hyperbola curve. That's the normal curve. Normal people, if they are obese or if they are non-obese, they will move along this hyperbola curve. And you can see if we have non-obese, they are better insulin sensitivity. Here they are still normal glucose tolerant. They have lower insulin sensitivity because they are obese, but they have higher secretion, so they can compensate and still stay within the good range. Here's the good range, here's the bad corner. And here you clearly see women are more sensitive, regardless if they are non-obese or obese. But with progression to glucose abnormalities, impaired glucose metabolism, or type 2 diabetes, with progression of the disease, you see that the differences between men and women are getting smaller and smaller and are almost abolished in type 2 diabetes. So if we look at healthy men and women, it's clear that menopause is a very important phase where glucose and lipid metabolism deteriorate. Postmenopausal healthy women show lower sensitivity, decreased beta cell function, have a more adverse lipid profile and higher blood pressure values compared to premenopausal women. So in women there is a clear change, a clear deterioration of metabolism with menopause, with the loss of estrogen. However, in males, we also looked in a big number of subjects in this study into more detail. In males, we did not find such changes of glucose and lipid parameters if the men were younger than 50 or older than 50 years, because in males it's not so easy to say when andropause starts, and it's even controversial if we should call it andropause. But on the other hand, if we have diabetic or even pre-diabetic women, then we already have this worse metabolic profile like postmenopausal healthy women. We also see it at the premenopausal stage. So diabetes diminishes cardiovascular protection in females, and that's probably one of the reasons why women have this increase in their cardiovascular risk, a higher relative increase of risk than males. So in the pathological sex differences, if we have obese and type 2 diabetic subjects, the males are detected with diabetes at younger age and at lower BMI. We have a little bit more males, as I already said. On the other hand, we have in the females maybe more often the metabolically healthy obese phenotype. If we can talk about a healthy obese phenotype, it's a matter of discussion. But in most studies it's shown that we have more often this metabolically healthy obese phenotype, and maybe this is also based on the fact that even if we have obese men and women, here we have obese pre-diabetic men and women, here we have normal weight men and women, and this is, here you see in green the subcutaneous abdominal fat and in red the visceral fat, and you can see that men always have more visceral fat, but even if they are obese or pre-diabetic, they have more visceral fat compared to the females, and the females have relatively more subcutaneous abdominal fat. And the visceral fat is the bad fat, so to say, so maybe this also contributes to the differences of diabetes incidence. Which parameters are the best parameters? If we look at anthropometric parameters, easy measurable parameters, if we want to estimate diabetes risk, there are studies showing that in men, BMI, very simple parameter, and waist circumference are comparable in their predictive value, so they seem to be as good. But if we look in women, then it's clear that waist, and there are many studies showing that waist is the best predictor. It's better than BMI. So waist is the best predictor of diabetes in women, and the best sensitivity and specificity for waist would be around 100 centimeter in males and 92 centimeter in females. So if you remember, it's very near to the cutoffs of metabolic syndrome. It's 88 in women and 102 in males, so it's very near these cutoffs. Let's talk a little bit about the sex hormones. It's interesting that in males, lower levels of testosterone are associated with a higher risk of diabetes. And in females, it's the controversy in females with higher androgen levels, higher testosterone levels, and here are meta-analysis, so there's really evidence of that. They have a higher risk to develop diabetes. And you all know polycystic ovary syndrome. It affects about 10% of women of reproductive age, and women with a polycystic ovary syndrome, they have about a 4-fold higher risk of type 2 diabetes. And there is also another female-specific form. I already talked about that. It's gestational diabetes. So let me stress again that women who had gestational diabetes, and it's very common, 15% if you remember, of all pregnant women. And even if you have a group of pre-diabetic women, as shown in the prevention studies, diabetes prevention studies, a group, all are pre-diabetic, still those with a history of gestational diabetes, they will have a 70% higher incidence of type 2 diabetes compared to the other pre-diabetic women. And if you compare women with normal glucose tolerance during pregnancy to those with gestational diabetes, those with gestational diabetes have a 7-fold greater risk of development to type 2 diabetes. So it's really a very, very high risk group, and we should develop prevention programs for this group, better prevention programs. Another point maybe to stress is that leisure time, no leisure time physical activity, no exercise, it has been shown that is more common in females, already in kids, already at school age children, but has a greater impact on obesity and is more closely related to abdominal adiposity in women than men. So maybe it's not the case in Israel, because when I was on the beach, I saw so many young people and also so many women running, jogging, and doing their exercise. So this is great. We should stimulate all women to do more exercise, because they have a great benefit of that. So just a pathophysiological model, different kind of picture. Insulin resistance is one of the main, of the key parameters associated with hyperinsulinemia in the development of type 2 diabetes. We talked already about many differences between the sexes. Also, what I didn't mention is the hypothalamus, pituitary, adrenal axis, which is also important, is more stimulated in females. Females and males also have different stressors, different coping styles with stress, but females seem to be more vulnerable, have a higher activation, and also stress seems to be very important for men and women in the development of diabetes, but maybe a little bit more in females. And this all contributes to hypertension and cardiovascular disease. So let's turn to gender-related work-related factors. Here it was shown that low decision latitude, and in particular low decision latitude in combination with high demands, is associated with a higher risk to develop type 2 diabetes in women. So it's fourfold higher risk in this case, high demands, low decision latitude. In males, there was not really a significant effect, at least in this study. And in males, there were even protective effects if they had high work demands and high strain and high decision latitude. So there seem to be differences. And it may be that in women, the association between job strain, work stress, and type 2 diabetes is more strongly mediated by obesity. At least there are some data pointing to this. For example, also in this study, they cross-classified participants by body weight status and exposure to work stress, and what they found is obesity in combination with stress in both men and women is associated with a higher risk, 2-, 3-fold higher risk, 4-fold higher risk to develop type 2 diabetes. However, if there was, for example, obesity but no stress, it was still a higher risk in men, but the risk in women was much lower. And night work, shift work, it's also important for people in the healthcare, working in the healthcare system. It seems it's a little bit controversial. There are many studies now and more studies in the recent half a year. But it seems that it also has a little bit more impact in females. If you look at this study, after 20 years of exposure, there was a trend observed among men for a positive association between night shift work, and diabetes, and on women there was a linear association between exposure to night work and development of type 2 diabetes. And adjusting for confounders, including obesity, they calculated that the risk of diabetes, if the night work was more than 20 years, it's about 40% increased in women, and there was a very weak trend only observed in men. So, as summarized in the review, it's a little bit controversial, but it points to the fact that there seems to be higher vulnerability to psychosocial stress in females in the development of type 2 diabetes. And this was also shown by us and many other groups, that low education also has a greater impact in women, and also low socioeconomic status, though it's important for both, for men and women, for development of obesity and type 2, but stronger effects in women. Shortly coming to the comorbidities and complications. Again, women seem to have higher rates of physical limitations, but also cognitive limitations and geriatric conditions if they are diabetic. And as you all know, they have also, if they are diabetic, higher rates of depression and anxiety, but that is like always also in non-diabetic subjects, we find this doubled rate in females. And reproduction is another very important topic in obesity and diabetes. We don't have time to discuss this in more detail, but just to remind you that pregnancy complication, it's very important for diabetic women. They have a much higher complications rate, still higher, and they have to plan their pregnancy and so on, so it's a topic for its own. And sexual dysfunction, I think everyone is familiar with the fact that males, diabetic males, have a higher risk of erectile dysfunction. I think this is known. Maybe what's not still neglected very often is that erectile dysfunction can serve as a really alarming marker of risk of future cardiovascular disease. So every man with erectile dysfunction should be checked for his cardiac function. That's very important. And erectile dysfunction can be an early sign of diabetes, can be a late complication. So we have to address that, but also females. There are many studies now showing that also diabetic females, every second woman seems to have some problems, some sexual dysfunction, and this is mostly not addressed at all in our clinical practice. So maybe we should pay more attention to that. So the very important vascular complications, the number one causes of death in all patients, also in diabetic patients, clearly shown, meta-analysis, big evidence that women have diabetes as a risk factor for incident coronary heart disease plays a bigger role in women than men. So we clearly see that the risk is about 3-fold increased in women to 2-fold increased in males. And the same you can see with stroke, again, meta-analysis, women, and regardless if it's type 1 or type 2 diabetes, but here it's for type 2 diabetes, have a greater risk of stroke. So again, compared to males, a greater risk. And this was independent of sex differences in other major cardiovascular risk factors. So we have to address more research and clarify biological, behavioral, and social mechanism involved in this important sex dimorphism. Who dies earlier? It seems that diabetes costs more life years in women than in men. There are some studies showing that. So overall, relative increase of mortality is higher in women. And only for morbid obesity, very clearly, it's a greater impact in men. But vascular causes, or also if they have end-stage renal disease, another important late diabetic complication. If they are on dialysis, then females again have excess mortality if they are diabetic. So just very shortly, some sentences regarding therapy. We have now interesting data also on sex-specific effects of anti-hyperglycemic drugs. Of course, there are also differences in lifestyle, but if we come to the drugs, for example, metformin is our basic drug, our first-line drug, and it was shown to reduce cardiovascular risk in both men and women, but it has also some anti-cancer effects, maybe. In many studies, it was shown that it's associated with lower risk, for example, for breast and colon cancer in women, and hepatocellular cancer in males, so maybe also some sex dimorphic effects. Glitazones, pioglitazone, I don't know if it's used in your country. In Austria, we use it. It's associated with higher rates of fractures in postmenopausal women. And so this is also noted in the prescriptions. So if you have an old woman, postmenopausal, with high risk of falls or osteoporosis, so don't give glitazone to that woman. Or the SGLT2 inhibitors, our latest class of drugs, very important class. It lowers obesity, it lowers blood pressure, it was associated with decreased mortality in their latest studies. So still there are more side effects in women. Women were shown to have more often urinary tract infection and genital mucosis, and this also has to be considered. And insulin, if we have to give insulin or combine insulin with oral drugs, then it's important to know that women have a much higher risk of hypoglycemia. We have shown this, and many other groups also showed this in the meanwhile. And this is strange because in most studies, women do not reach their HbA1c goals like men do. So they are always worse. They have worse metabolic control. But still, despite this worse metabolic control, they have a higher risk of hypoglycemia and also severe hyperglycemia, severe nocturnal hyperglycemia, so really dangerous situations. And we know hypoglycemia is also associated with higher cardiovascular risk and mortality. So, and in this particular, it's non-obese women. So if you have lean women with diabetes, so be careful, start slow with insulin and increase the dose more slowly. There even is now from the American Heart Association a scientific statement regarding sex differences in cardiovascular treatment and intervention in diabetes, which we just cannot go into detail, but just for the first point, women have lower frequency of lipid-lowering therapy, statins. They have lower aspirin use, lower ACE inhibitor, lower beta blocker use, and also that's interesting because I didn't know that, but there are more and more studies showing the same direction. They have lower medication adherence, at least regarding statins and cardiovascular medication. So I would have thought it's the other way around, but studies showing that they have lower medication adherence. But I think maybe it's because they have more side effects, because it's shown in many studies they have more side effects. In particular, if we think about statins, they have more frequently myalgia if they take statins, and even it looks like that the likelihood of developing diabetes if they are on statins is a little bit higher. There's not really evidence for that, but the studies showing higher diabetes incidence if you are on statins, they show more females than males, but it's not significant. Yeah, and there are many other points, but maybe just going to the lifestyle. As already said, exercise is very important for women. However, observational studies suggest that women with diabetes require greater frequency, greater intensity of physical activity to achieve their goals. So that's a pity. But on the other side, the Dachin study, and this is not a very good study because there are many bias, but it's the only study, the only diabetes prevention study where they really have long-term follow-up data. They have more than 20 years follow-up. And they showed that women in the intervention study, which was about 5 years, so a long time ago, they had greater benefit, lower cardiovascular mortality in the long term than men. So maybe lifestyle changes, physical activity has even a greater benefit in women, but we cannot really say because there's not enough evidence right now. What we can say, and we did such meta-analysis for prevention studies, it was very difficult. We couldn't include all studies because we did not get the information stratified by sex from many studies. Unfortunately, the publications are not very good, and even the authors could not give us the details, but we could include many studies, and we saw that there is no difference between men and women. So diabetes prevention is effective in both, in males and females. So maybe it looks like that it's a little bit more effective in males, but this was not significant. And if we look at weight loss, again, it seems that males may be a little bit greater benefit, but again, no significance. So healthy lifestyle works in both sexes. That's important. And just to conclude, two studies I find interesting, very recently published. It's one study from Israel, this study, and one study from Sweden, and they were studying recruits. And they showed that it's very important, your body mass index and your physical fitness already at the age of 18. So we really have to start very early. The best thing is to start during gestation. But they looked at adolescents, a huge number of Israeli adolescents, and here we have the advantage that it's males and females, as you know, you are aware of that. And they showed that the minimal risk of diabetes mortality, they don't have other data later on, but they just have the BMI values at the recruits, when they were recruits, and then they related this to the mortality data with the cause diabetes. And what they showed that the lowest risk was with a very low BMI at the age of 17, 18, so it's really low. And even within the normal range at this age, it's up to 25, as you know, they have already a higher risk starting from 22 kilogram per square meters BMI, they have the higher mortality risk later on. And if they are obese already at the age of 17, then it's really a huge increase of risk. And they also showed that male sex, lower socioeconomic status, lower education, North African and former Soviet Union origin and shorter stature were also associated with higher mortality risk. So that's interesting. And the other one is the same direction. It's from Sweden. They only have males. Again, they studied military conscripts. And what they showed is that just not mortality, just diabetes, cumulative diabetes incidence. And they showed the boys with low aerobic capacity and low muscle strength at the age of 18, they had a much higher risk of diabetes later on. They followed up to 30, 40 years of age. And this was an additive interaction between aerobic capacity and muscle strength, and those with the lowest values had a threefold higher risk. So it looks like that poor physical fitness levels during late adolescence are important, and that is also important, are modifiable risk factor for type 2 diabetes in later life. So maybe we should pay attention to our adolescents. So to sum up, it's very clear that both sex difference, biological factors play a very important role. The differences in genetic susceptibility and epigenetics and sex hormones. But on the other hand, we also have the big impact of gender roles, of culture, of lifestyle, and both have to be considered. And if we want to do modern personalized therapy, it's very important that we also include sex, not only age and BMI and all the other factors, but also sex and gender in our concepts for treatment and prevention. Thank you. Sorry, I just forgot to mention, I have to say that we have a postgraduate course, a 2 years ongoing postgraduate course at the Medical University of Vienna, and if anyone is interested, it's a long distance, I know, but still we have this course, and it's the only one, I think, at the moment where you really can finish the study with a Master of Science of Gender Medicine. Thank you.
Thank you very much. Questions and remarks from the audience? Yes, please, Professor Pasaman.
I just wrote a brief remark that indicated that women have a worse compliance to patients. And this is probably overboard, because if we take into account that most drugs have been studied in men and applied to women, looking at the different composition of the body, so one can safely say that many women receive many drugs at a certain overdosage. And we should not be surprised that we see also more side effects, opiate treatment, energetic treatment, so those are therapies.
Yeah, thank you. But I was still astonished because sometimes I had the feeling that that males are less adherent, but it doesn't seem to be true. And maybe it's also other things, like women like to discuss more. If you give a pill to a man, he's happy. He's, great, my problem will be solved. I take this pill no matter the dosage, does not matter. He does not ask very much, and he takes it as long as you prescribe it, and then it's finished, and he wants that everything is gone. But the female, if you give a pill to a female, she will ask if there are alternative ways, other drugs, if she can try lifestyle once again or change something in her life again, because she does not want to take the pill. So maybe also there are more complex things. We have to spend more time explaining the advantages and disadvantages, discuss more efficiently side effects, I don't know. Or do the women maybe even do not report side effects to the doctor? Maybe they don't tell the doctor, or they don't want to discuss with the doctor. I don't know. So yeah, that's communication. So maybe we should also change our communication, thinking about the low adherence rate or the lower adherence rates of women.
Thank you very much. I would like to add another question. You showed us that the risk for developing diabetes is not the same in men and women regarding the BMI category. Meaning that in lower BMI, men develop a higher rate of diabetes. I want to ask you if it is true for all age groups of women, meaning premenopausal and postmenopausal. Is there a role, for example, for estrogen as a protective agent against the development of diabetes?
Yeah, I'm sure it is, because estrogen increases insulin sensitivity, and it's also responsible for the different fat distribution. So that they have less visceral fat, less liver fat is also related to estrogen levels. And we also know that after menopause, the increase of adiposity is even much more prevalent than before menopause. So, and they also get more the male phenotype. Women after menopause, they change their body fat distribution more in the male direction. So I'm sure this also is very important, yeah.
Thank you very much.